These results suggest that chronic burnout is associated with heightened somatic arousal and elevated salivary cortisol levels. This may be part of the mechanism underlying the emerging association between burnout and risk of cardiovascular disease. So we see that cardiovascular disease is like the #1 killer in America. So let's look at whether stress, and we all know that stress is associated with it, but why is that? Because it increases sympathetic nervous system and epinephrine and norepinephrine. Now, we've been talking about cortisol, and cortisol is at the end of this normal stress response. So let's look a little bit earlier at the sympathetic nervous system at the beginning here and see if there's a way that we can measure that and how it might affect cardiovascular disease and other problems that are associated with stress. Now, the sympathetic nervous system, what is it going to do? Let's start from the beginning. The heart rate has pace cells. It has normal rhythm cells. And if you denervated the heart would beat at about 100 beats per minute. And you can see all of these lines start at around 100 beats a minute. Now, the parasympathetic nervous system slows the heartbeat down, and the sympathetic nervous system speeds the heartbeat up. Now, the net effect of the autonomic nervous system is this heart rate variability, and that's what we're talking about, heart rate variability. And this is very important. Salivary testing and heart rate variability are probably the most important things that I have understood in my career that has changed the course of my career. And I didn't know that even in my prior life as an OBGYN, we looked at heart rate variability to determine whether or not a baby was under fetal distress. And we were looking at this variability. And what we're looking at is how much stress, the sympathetic nervous system, and is it balanced out by the parasympathetic nervous system? What should happen is that any imbalance is considered to be a stress by the body. And the sympathetic nervous system should notice that imbalance, it should correct that imbalance, and then the parasympathetic nervous system should come in and calm the heartbeat down and wait for that next stress. Now, this is a lesson from my past. This is very evident here. The stress is the contraction, which is on the bottom row here, and the heart rate variability is at the top. Now, the stress is the contraction, and you can see here that if we're looking at the heart rate increases when the body detects, when that fetus detects that contraction. You see it's at the very beginning. And what should happen is that it identifies the stress, it adjusts to the stress, and then it goes back to having this heart rate variability again. So this is the normal response to stress. I see the stress, I adjust to the stress, and I recover from the stress. This is a great heart rate variability pattern in a fetus. Now, this is a poor heart rate variability. You see that the sympathetic nervous system has increased the resting heart rate to 160, where here the resting heart rate is it's around 140, 150, where it should be. So the resting heart rate is at 160, and what you see here is that there is a decrease in the heart rate after the contraction. You see that there's no acceleration at the beginning of the contraction, and you actually have a deceleration at the end of the contraction. That means that the baby is having a hard time noticing the stress, adjusting to the stress, and is really having a hard time recovering from the stress. Now, this is what you see if we're looking at it on a rhythm strip. And you can also do this in an adult, because this does not change once the baby comes out of the womb. You can look at heart rate variability and you can see the strength of the sympathetic and the parasympathetic nervous system. You see there's good heart rate variability and then there's bad heart rate variability. So when you're looking at heart rate variability, what you're doing is you're measuring the distance between the heartbeats. And this is happening second by second. The body should be taking care of small imbalances so that they don't become big imbalances. Take care of the small stress, recognize it, adjust to it, recover from it. And so you can measure these, and you should get, what you do is you measure the distance, and then you turn the lines 90 degrees, and you get these types of patterns. So this is good heart rate variability, is a healthy sympathetic nervous system. You get a lot of variations. And remember that I told you, when you're under stress, your body will sacrifice the parasympathetic nervous system in order to make sure that the sympathetic nervous system is ready to function. So this is a normal heart rate variability, and then this one is abnormal. And this is what you will see when cortisol is involved, because remember, the neurotransmitters should be like flashing lights. And so there's quick adjustments. You know, it's norepinephrine, serotonin, it's released and then it's reuptaken. And so you can make quick changes. Cortisol is a hormone. Remember, it was a rhythm. It took days to change it. So if you are depleted of neurotransmitters, then cortisol is going to take over, and that does not respond quickly. And so you get this flat type of heart rate variability. And what do we see when we see a sudden stressor? Well, that's all from that sympathetic nervous system, increasing blood pressure, heart rate, and heart contractions. So stress and cardiovascular disease, we know that that is going to tax the cardiovascular system. Let's look at heart rate variability and hypertension. And we look in the yellow portion here. These findings are consistent with the hypothesis that autonomic dysregulation is present in the early stage of hypertension. Now, if you read here, is that heart rate variability is very important when you're looking at the risk of future cardiac events, especially if someone has had a previous MI. And there's a 50% increase in the risk of cardiac events over the next 3.5 years if a person has an abnormal heart rate variability. Now, the other reason why stress is involved with cardiovascular disease is that when everything is going toward cortisol, you're not making mineral corticoids. And mineral corticoids will, the lack of mineral corticoids will cause you to lose electrolytes. And magnesium is especially important electrolyte to lose. Reactions mediated by stress hormones are increased by low magnesium calcium, which further reduce tissue magnesium levels. Low magnesium calcium favors vasoconstrictive and platelet aggregating factors. It can lead to hypertension, is implicated in eclampsia and cardiac arrhythmias, and may well be to blame for sudden cardiac death associated with stress. Most people are magnesium deficient, as a lot of you may know, and this alters the electrical conductivity of the heart. Thus, stress, whether it's physical, emotional, or pain, or excitement, or depression, increases the need for magnesium. So it's worth consideration a trial possibly higher than usual magnesium intake for patients who are dealing with a lot of unusual stress. Now, if we look a little bit further down this pathway, as stress becomes more chronic, you'll see that cortisol continues to go up. And what happens is, because everything's going toward cortisol, you'll get an elevated cortisol to DHEA ratio. If you see down here at the bottom here, elevated cortisol to DHEA ratio. And when you have that, you have disruption in energy production, other influences, and also the immune activity. So let's start on the left here. And what we will see here is that when cortisol is predominant and DHEA is decreased, you have a decrease in insulin sensitivity. We know about insulin resistance. We have a decrease in proper glucose utilization. Blood sugar levels go up. Again, this is great if you're running or fighting. And then gluconeogenesis increases. Now, if you take all of those together, that is the definition of insulin resistance. So now we can see how stress can lead to insulin resistance, because it is what happens when DHEA is sacrificed in favor of cortisol. So insulin resistance can lead to type 2 diabetes. Now, at the top of this, you see that there's obesity, there's diet, there's age, and then there's stress. But I really think that stress should be at the top of this, because we saw how stress can lead to obesity. Stress can change your diet, because if stress increases norepinephrine, epinephrine, and decreases serotonin, you will begin to crave carbohydrates, because that is a way to increase insulin and serotonin. So stress can change the way you eat, and stress definitely can age you. If you look at any of the presidents, Obama, Bush, Carter, all of them aged more than the 8 years that they were in office, or 4 years for Carter. So stress influences even the top 3 influences that lead to insulin resistance. So first you get insulin resistance, and then you get hyperinsulinemia. And then you get an increase in pancreatic beta cell mass trying to produce more insulin. And that is done in order to keep your blood glucose normal glycemia. And then you begin to have impaired first phase insulin secretion and postprandial hyperglycemia. And after 50% of your pancreatic beta cell mass has died through apoptosis, then you get hyperglycemia and type 2 diabetes. So there's a long road between peripheral insulin resistance and type 2 diabetes. Now, we saw again how stress increases visceral adiposity and can decrease bone and muscle mass, which is what we see in insulin resistance. Stress and cardiovascular disease and insulin resistance, they all go together. You get vascular insulin resistance, and that leads to inflammation. Then you get endothelial dysfunction, and that can lead to atherothrombotic cardiovascular disease. We know that insulin resistance and diabetes especially affects small vessels. So if we're going to practice functional medicine, we don't want to wait and diagnose patients when they actually have diabetes. We are taught to diagnose diabetes when the fasting blood sugar is above 120, 125. They keep changing what that level is. But by the time you have diagnosed diabetes, you can see there's all types of complications. There's atherogenesis, you have hypertension and dyslipidemia, you have microvascular complications. So we're right at the beginning of microvascular complications, which can be deadly, can cause gangrenous limbs, can cause problems with cardiovascular disease. We want to be able to diagnose this earlier when insulin sensitivity goes down and insulin secretion increases. We need to measure the insulin level and the glucose level in order to prevent diabetes and to arrest insulin sensitivity early on. Is insulin bad? No. Too much insulin can be bad. Too little insulin can be bad. If you have the right amount of insulin, it causes vasodilatation. It causes growth inhibition. It's antithrombotic, anti-inflammatory. But if you have too much, it causes vasoconstriction, growth promotion, and prothrombotic. So we saw the stressed and wired. Now this is what we would determine tired and then wired. What happens is that the adrenal gland initially is, full speed ahead, but then it begins to fatigue. It begins to wear down. And what happens is your adrenal gland begins to ration out cortisol. It says we can only make this much cortisol throughout the day, and we're going to make the same amount whether you're waking up or whether you're going to sleep. And so you don't have enough cortisol for get up and go in the morning, and you have too much at night, so you can't go to sleep. So this is sometimes confusing. So how can I be tired, but I can't go to sleep? Because you have to have normal cortisol levels in the morning so that you can, have some energy, and then you have to have decreased cortisol at night so you can go to sleep. So this is a pattern that we often see. So when you're like this, what happens is you never function optimally. You're either alert and the slightest little thing takes you over to anxiety and disorganization. So it really just takes out your peak performance when you can't make your normal amount of cortisol, especially at the right time of day. Now, it's been shown that early loss experience appears to be associated with decreased salivary cortisol responses to awakening. Low cortisol awakening responses are believed to reflect altered dynamics of the hypothalamic pituitary adrenal axis, possibly conferring risks for certain stress-related disorders. This is a case where this early loss experience really hit home for me. I had a patient who, I was just learning this, I had a patient who said that she hadn't slept more than 2 hours uninterrupted for about 30 years. And at first you think, she's exaggerating. But this patient was 38 years old. And I asked her, what went on when this started? What happened about when you were 8, 9 years old, or really around 7 or 8 years old? Because usually what happens is that you can deal with the stress for a year or two. And that's when the adrenal gland begins to wear down and you start to get this pattern. So actually what she told me was about a year or two before that, her father left the family and she woke up and she never saw him again. And so in her mind at 6, 7 years old, she decided that she didn't want to go to sleep at night because she was afraid that she would wake up and her mother would be gone and she'd be all there by herself at 6, 7 years old. And so what she did was, with time, she elevated her nighttime cortisol so she wouldn't go into a deep sleep. Well, she kind of got stuck there, like living out in California. You know, you change your circadian rhythm. So she changed her circadian rhythm, and her nighttime cortisol was always elevated, even though she's 38, 40 years old. So what we did was we gave her adaptogen so that she could normalize her curve. We gave her the phosphatidylserine, and it lowered her nighttime cortisol. The way it works, it resensitizes that feedback loop so that you recognize that that cortisol is too high. And I think I'll show you that in a few slides. But that early loss experience can be like that. Now, I'll tell you another way that this happens is that when a person has a baby, when a mother has a baby, she will elevate her nighttime cortisol. And that's why she can hear that baby, even without a monitor. She can hear that baby in the middle of the night, way across the room, way across the house, because she really doesn't get deep sleep. And most mothers will contest to that. Now, fathers don't have that same ability. They don't get that same instinct. That's why the baby can be screaming to the top of his lungs at 2 o'clock in the morning, and you're pushing your husband, say, don't you hear that baby? And he gets up and says, what baby? I didn't know you had a baby. He's totally out of it while you've been awake since the first whimper. So that is a way that even Mother Nature allows us to have that one eye open. Now, the problem is sometimes mothers will find that they have a hard time sleeping even when the baby is 2, 3 years old, because they've gotten stuck like that, or maybe they had a previous SIDS baby. These mothers will complain of not being able to sleep, years later. So that is one way where you can see that a cortisol curve can make a change and can cause significant symptoms. And sleeping pills aren't going to help that. You have to reestablish that normal cortisol curve. Cortisol after awakening was significantly decreased in primary insomnia. So they saw patients who had insomnia had decreased morning cortisols. Salivary cortisol at the time of awakening correlated negatively with the subjective estimation of sleep quality. A low salivary cortisol level directly after awakening correlated with a higher frequency of nightly awakenings. So they were only doing one measure. They were just doing the morning cortisol. But they found that, hey, the people who had low morning cortisols also said they woke up a lot at night. When patients have a high nighttime cortisol, usually they'll say they wake up at 2 or 3 o'clock in the morning. They can set their watch by it, and it may take them 2, 3, 4 hours to go to sleep. A lot of times they say they can't go back to sleep until it's time to wake up again. That is a high nighttime cortisol until proven otherwise. Usually if patients have a hard time going to sleep, that may be more of an estrogen progesterone problem or a neurotransmitter problem. But if they wake up at 2 or 3 o'clock, because that's when they should be going to that deep sleep, what can happen during that time is that they're halfway awake. So if a door outside closes, if the heat or the air conditioner turns on, they hear it and it wakes them up. Sleep duration in breast cancer. So we're going to talk about the immune system and natural killer cells. Analysts they restricted, analysis was restricted to 7,300, almost 7,400 women. And they were measuring the sleep duration, and they did it for 6 years, 1975 to 1981. And what they did was they divided groups into patients who got less than 6 hours sleep, patients who got 6 to 8 hours of sleep, and then patients who got 8 hours or more of sleep. And what they found is that the patients who got 6 to 8 hours of sleep, less than 6 hours of sleep, they had a 1.1 confidence interval. So they had a 10% increased risk of breast cancer. Now, the people who slept 6 to 8 hours had about a even chance. They had no increased risk. But the patients who slept 8 hours or more, they had a 0.28 incidence. So that means they had a 72% less risk of breast cancer because they slept more. So this study provides some support for decreased risk of breast cancer in long sleepers. So what could be going on when you are asleep? Well, this is when the immune system functions, when you're asleep. Well, when you have a high cortisol and a low, or a cortisol to DHEA disruption in that ratio, secretory IgA is decreased. So that's what lines the mucous membranes of your respiratory system and your GI system. So that is your number one defender against the antigens from the outside. So antigen penetration increases, circulating IgG increases, so you have more inflammation. Natural killer cell activity goes down, and these are the cells that survey mitosis and make sure that there's no mutations or there are no cancer cells, and it kills them before they're able to multiply. And interleukin-2 and T lymphocytes are decreased. So these are all immune system functions that are decreased. Patients with metastatic breast cancer whose diurnal cortisol rhythms were flattened or abnormal had earlier mortality. Suppression of natural killer cell count and natural killer function may be a mediator or marker of more rapid disease progression. So it's very important that you have a normal cortisol rhythm when you're worried about metastatic breast cancer recurrence. Now, this is an article that was written by Dr. Sapolsky. He's the same one who wrote the book, Why Zebras Don't Get Ulcers. And a lot of times we're worried about how much estrogen or how much progesterone or testosterone we should put a patient on when they have breast cancer, but we really should be looking at their cortisol because they have a more rapid disease progression. And that's why patients who have extended families that help comfort them, they may have a dog or whatever, this is normalizing their cortisol. And we know that breast cancer or cancer patients who are in a supportive environment and seem to live longer because of this normalization of cortisol that they get from that. So this is just showing how stress affects the immune system, and we can look even more. At the individual patient level, survivors who reported the highest level of fatigue also had the flattest cortisol slopes. Results suggest a subtle dysregulation in hypothalamic pituitary adrenal axis functioning in breast cancer survivors with persistent fatigue. As the adrenal gland continues to deteriorate, now we see someone who's stressed and tired. They don't have any energy in the morning, afternoon, or evening. We conclude that the improvement in fatigue seen in some patients with chronic fatigue syndrome during hydrocortisone treatment is accompanied by a reversal of the blunted cortisol responses to cortical-releasing hormone. So if we're talking about bioidentical hormone replacement, you can actually use cortisol to replace low cortisol in patients who have extremely low cortisol. Now, a lot of times when I say cortisol, people hear prednisone, but cortisol is different. Prednisone is 4 times as potent as cortisol. This is an endocrinologist, I think he's passed away now, but Dr. Jeffries wrote an excellent book on the safe uses of cortisol. And cortisol used properly actually does what it should do. It releases glucose for energy. It actually improves the immune system. And cortisol is like every other hormone. Too much is not good and too little is not good. But physiologic levels of cortisol can be very beneficial. These results suggest that there is a relationship between adrenal cortical function and disability and chronic fatigue syndrome, but do not reveal the causal connection. So chronic fatigue can be based on cortisol responses or levels. The cortisol response to awakening was associated with concurrent fatigue and poor sleep quality. These findings suggest a subtle HPA hypoactivity and vital exhaustion, which may arise through chronic stress and associated sleep disturbances. Patients have a lower cortisol response to awakening measured by the area under the curve. This naturalistic test of the HPA axis response to stress showed impaired HPA axis function in chronic fatigue syndrome. So this is what is really going on when a person says, I'm tired all the time. They usually have a disturbance in their HPA axis. Now, this is what you find when a person is totally has adrenal fatigue or no cortisol at all. You get decreased cortisol to DHEA ratio, you get gluconeogenesis, hypoglycemia, hunger, depression, low energy, allergies, inflammation. These are all the symptoms: headaches, dyspepsia, poor memory, fatigue. And this is actually a copy of the symptoms that I stated when I first talked about Ms. Jones coming in and how she's frustrating to everybody, and we do all of these tests. What she's really trying to tell us is that she has a disruption in our HPA axis. And if you determine the dysfunction in our HPA axis, Ms. Jones will be happy and she won't bother you again.